Bismillah ar-Rahman ar-Rahim. Our lecture is about CT and MR radiological anatomy for skull base. By the end of the lecture, we should learn the CT and MRI radiological anatomy of the normal skull base, identify skull base foramina and their contents. Imaging of a skull base will help in identifying the lesion, diagnosis, extension of the lesion, resectability, treatment planning, and follow-up. All skull base necessitate both CT and MRI in the diagnosis. Normal skull base extend anteriorly from the root of the nose, posteriorly to the superior knuckle line here. As we can see here, this is the superior knuckle line. The skull base is divided into three components: extracranial, the osseous part, and the intracranial part. Regarding the extracranial space, it is divided into many parts, as we can see: the masticator space, the parotid space, pharyngeal, parapharyngeal space, pharyngeal mucosal space, carotid space, perivertebral space, retropharyngeal, and danger space. Again, in another section: masticator space, parotid space, parapharyngeal space, carotid, pharyngeal mucosal, retropharyngeal, danger space, and perivertebral spaces. The danger space is called so because it is a space extending from skull base to the mediastinum, formed of loose areolar connective tissue. Infection spread easily in that space. Now the intracranial part is formed of anterior cranial fossa, middle cranial fossa, and posterior cranial fossa, bounded by lesser wing of sphenoid and petrous ridge, dividing the skull base into three parts. Generally, the skull base formed of 5 bones: frontal, ethmoid, sphenoid, temporal, and occipital. We'll discuss each one in details. This is the anterior surface of the skull base, as we can see, containing multiple bone features and foramina. Regarding the anterior cranial fossa, in the frontal bone, we have foramins like the foramen cecum. This is the location of the foramen cecum. It has emissary vein connected to superior sagittal sinus. In the CT, this is the location of the foramen cecum, as we can see. This is a small hole anterior to the crista galli. This is the crista galli in the sagittal plane, and this is the foramen cecum. Along the midline carries, as we said, emissary vein from the nasal mucosa to the superior sagittal sinus. It's important to spread of infection from extracranial to intracranial parts. The other bone in the anterior cranial fossa is the ethmoid bone. It has multiple bony features. We'll name them in details now, and 2 foramina, anterior and posterior ethmoid, as we can see, also having ethmoidal vessels. Now, regarding these features, we have in the midline the crista galli, just lateral to it the cribriform plate. Then we have here the fovea ethmoidalis, And of course, this is the orbital braid of the frontal sinus. Again, this is the crista galli, the cribriform plate. This ascending bone is called the lateral lamella, and this one, this is the fovea ethmoidalis. Crista galli, cribriform plate, lateral lamella, and fovea ethmoidalis. In MR, we can appreciate the olfactory bulb inside the cribriform plate. Middle cranial fossa, now composed of the temporal bone with its parts, squamous, vitreous, mastoid parts. It has many important foramina and canals, such as the jugular foramen, carotid canal, internal auditory canal, facial nerve canal, and Eustachian tube. The jugular foramen, this is the jugular foramen, formed by the petrous part of the temporal bone and the occipital bone. It has two compartments, one small anteromedially and one large posterolaterally. The small one is called pars nervosa and the large one is called pars vascularis, divided by jugular spine or crest. The pars nervosa contains inferior petrosal sinus and cranial nerve 9, while the pars vascularis contain the jugular bulb, cranial nerve 10 and 11. In the coronal CT, this is the site of the jugular foramen. This is another thing, this is hypoglossal canal. This is the jugular foramen. As we can see here, this is the two compartments of the jugular foramen, pars nervosa and pars vascularis. In the MR, we can appreciate the petrosal sinus draining into the jugular bulb. The carotid canal, the second foramen, of course it is a passage within the petrous temporal bone, transmits the internal carotid artery and sympathetic plexus. It has inferior opening called the carotid foramen. This is the rounded carotid foramen, anterior to the jugular fossa, as we can appreciate here. The carotid canal is initially directed superiorly, then turns anteromedially to reach up the petrous apex. It runs approximately 2 cm within the petrous bone and open into the middle cranial fossa superior to the foramen lacerum. Now, first we have vertical portion. This is the carotid foramen, as we can see, corresponding to this one. Then we have the horizontal carotid canal, as we can appreciate here. So in the basal cuts, we will have this foramen corresponding to the vertical portion of the carotid artery, then the horizontal carotid canal like this, coursing medially into the middle cranial fossa. Internal auditory canal, as we can appreciate here, located in the petrous part of the temporal bones, runs laterally, contains facial nerve, vestibulocochlear nerve, and labyrinthine artery. Normal diameter varies from 4 to 8 mm, considered narrowing if less than 2 mm. Regarding the arrangement of structures within it, this is a nice diagram. This is the anterior part, posterior, superior, and inferior. We have here the 7th cranial nerve, here the cochlear branch of the 8th, here the superior division of the vestibular nerve, and the inferior division of the vestibular nerve. So this is 7 up, corresponding to 7th nerve. Coca-Cola corresponding to the cochlear branch of the vestibulocochlear nerve. And the MR, of course, we can appreciate here 7 and 8 cranial nerves. Facial nerve canal. We have two obvious parts here. This is the labyrinthine part, and this is the tympanic part. The labyrinthine segment of the facial nerve coming from the internal auditory canal here, angle sharply forward, nearly at right angle to the long axis of the petrous bone. This is the long axis of the petrous bone, nearly at a right angle, to reach the geniculate ganglia. Here is the geniculate ganglia. At the ganglia, the facial nerves makes a U-turn like this. This is called the first genu of the facial nerve, to run posteriorly as the tympanic segment. This is the tympanic segment, along the medial wall of the epitympanum. So we have the labyrinthine, the genu, and tympanic segment. In the CT, in the basal cut, we have here the tympanic segment. This is the tympanic segment of the facial nerve. This image at the level of the internal auditory canal. We have the internal auditory canal. The tympanic segment of the facial nerve is seen just medial and parallel to the wall of the epitympanum. Medial and parallel to the wall of the epitympanum. The head of malleolus is seen anterior to the head and short process of the incus. This is the malleolus and incus. So this is the tympanic part of the facial nerve. In a higher section, this is the ice cream cone appearance. Here the geniculate ganglia of the facial nerve. This is the level of the aditus and antrum, the connection between the tympanic cavity and the mastoid antrum. In this level, the labyrinthine segment of the facial nerve coming from the internal auditory canal angles sharply forward, nearly at right angle to the long axis of the petrous bone, to reach the geniculate ganglia. Here is the geniculate ganglia. Also we can appreciate this is the labyrinthine segment, and this is the tympanic segment. This is the U-shaped, and the first genu here corresponding to the ganglia. Eustachian tube, as we all know, this canal connects the nasopharynx to the middle ear cavity, as we can appreciate on high resolution CT here, from the nasopharynx to the middle ear. We spoke about the temporal bone and its foramina. Now we will discuss the sphenoid bone in the middle cranial fossa and its foramina. Regarding bone features, we have greater wing of sphenoid, lesser wing of sphenoid, and basisphenoid. The basisphenoid, composed of the dorsum celli, posterior clinoid process, sella, and tuberculum celli. Regarding the foramina here, we have foramen ovale, spinosum, rotundum, optic canal, superior orbital fissure, precavernous carotid canal, foramen lacerum, which is not a true foramen. Now, regarding the CT, greater wing of sphenoid corresponds to the red tagged areas, as we can appreciate, while the lesser wing of sphenoid, it is the bone where its anterior end is the anterior clinoid process. So this is the lesser wing because its continuation will end in the anterior clinoid process, while the greater wing, it is the basal bone. So this is the lesser wing of sphenoid, and this is the greater wing of sphenoid. In the cuts of the CT, this is where we can appreciate the greater wing of sphenoid. Largest foramen here, it is the foramen ovale. This is the foramen ovale. We'll appreciate here in the central part of the middle cranial fossa, located at the posterior base of the greater wing of sphenoid, as we said before. Content mandibular branch from the trigeminal nerve, V3, accessory meningeal artery and emissary vein. So this is the foramen ovale. Again, this is the foramen ovale in the coronal plane, extracranial opening at the lateral pterygoid plate. Here, just lateral to the pterygoid plate, this is the foramen ovale in the coronal section. Again, transmitting V3, accessory meningeal artery and emissary veins. Posterior to foramen ovale is the foramen spinosum. It is a smaller one, located posterolateral to the foramen ovale. Content middle meningeal artery and meningeal branch of V3 or mandibular nerve. Foramen spinosum. Foramen rotundum. Foramen rotundum. This actually a canal in the base of the greater sphenoid wing, situated just inferior and lateral to the superior orbital fissure. The canal extends obliquely forward and slightly inferiorly, connecting the middle cranial fossa to the tricopalatine fossa. Now, as we explained, this is the greater wing of sphenoid, and this is the part of the foramen rotundum. This is the canal. It is described as foramen rotundum. The canal transmits the maxillary nerve, V2, artery of the foramen rotundum and emissary vein. So in the axial cuts, this is the site of the foramen rotundum, just lateral to the sphenoid sinus, as we can see here. This is the foramen rotundum. In the coronal section, it is just seen at near the wall of the sphenoid sinus, like this. This is the foramen rotundum. Vidian canal is located in the floor of the sphenoid sinus at the junction of pterygoid process and the sphenoid body, connecting the tricopalatine fossa anteriorly and the foramen lacerum posteriorly. So this is the Vidian canal. It is nicely seen, thin canal, and has sclerotic margin, as we can see here. Narrow canal with sclerotic margins connecting this area. This is the tricopalatine fossa to the foramen lacerum here. So this canal with the sclerotic margins is the Vidian canal, connecting again. This is the tricopalatine fossa to the foramen lacerum. Contains Vidian artery, branch of maxillary artery, Vidian nerve, greater superficial petrosal nerve, and deep petrosal nerve. Foramen lacerum, as we said, this is the foramen lacerum, located between the occipital condyle and jugular tubercle. This is the occipital condyle and this is the jugular tubercle. Runs anterolaterally. Contain the greater petrosal nerve, or internal carotid arteries overlie it. So this is the foramen lacerum. Now to summarize what we said, this is the trigopalatine fossa, Vidian canal, this is the foramen spinosum, foramen lacerum, foramen ovale, foramen spinosum. Here the trigopalatine fossa, and we will explain later other parts. And this is the foramen rotundum. You see the difference between the foramen rotundum and Vidian canal. The foramen rotundum is wider than the Vidian canal. The canal has sclerotic margins. In the coronal plate, here the region of the optic canal, superior orbital fissure, and we have two here foramina, Vidian canal in the base. Just superior to it is the foramen rotundum. This is the Vidian canal, and this is the foramen rotundum. So first we will, from the base, we will appreciate the Vidian canal, then the cut superior to it will appreciate the foramen rotundum. The optic canal, these are the optic canal, and these are the superior orbital fissure. You can see the difference in the directions. These are the optic canals, and these are the superior orbital fissure. Again, in the coronal plate, this is the optic canal, located in the posterior portion of the orbital roof. As we said, within the lesser wing of sphenoid, this is the lesser wing of sphenoid, because its continuation is the anterior clinoid process. Contained optic nerve and its meninges, ophthalmic artery, central retinal vein, sympathetic nerve fibers. And the MRR transmit, of course, the optic nerve. The superior orbital fissure, here is the superior orbital fissure. In the coronal plane, this area is the superior orbital fissure. This is the optic canal, and this is the superior orbital fissure. Located between the lesser and greater wings of a sphenoid. Contains cranial nerves 3, 4, 6, and the first branch of 5. Okay, oculomotor, trochlear, abducens, ophthalmic veins, nerves, ophthalmic veins, sympathetic plexus, orbital branch of middle meningeal artery, recurrent branch of lacrimal artery. So it contains 3, 4, 6, and first division of 5th cranial nerves. What about the inferior orbital fissure? Located inferior to the superior orbital fissure, this area is the inferior orbital fissure. Inferior to the superior orbital fissure. Bounded superiorly by the greater wing sphenoid, inferiorly by maxilla and orbital process of palatine bone, and laterally by the zygomatic bone. Contains maxillary nerve, zygomatic nerve, orbital branch of trigopalatine ganglia, infraorbital vessels, inferior ophthalmic veins. This is the inferior orbital fissure. To summarize the superior and inferior orbital fissure, here is the superior orbital fissure, and inferior to it, this is the inferior orbital fissure. And the optic canal, this is the optic canal. Regarding the posterior cranial fossa, it's much easier than the middle one. We have here features in the occipital bone, base occiput, which contains the clivus and jugular tubercle. This is the base occiput. Condyles, occipital condyles, and squamous part. The base occiput, condyles, and squamous part. The foramina has foramen magnum, posterior condylar canal, and hypoglossal canal. The foramen magnum, the largest foramen in the skull, situated in the occipital bone, along a line drawn between the basion and opiscision, here, define the borders of the opening. Contain spinal cord, medulla oblongata and meninges, vertebral arteries, spinal arteries, and nerves. Posterior condylar canals, two small holes in the condyles. The posterior condylar canal is the largest of the emissary foramina. Up to 80% of patients can be unilateral. This is in the MR, posterior condylar canals. Hypoglossal canal, this is the hypoglossal canal. This is in the coronal view. Situated in the occipital bone, located between the occipital condyle and jugular tubercle. Between the occipital condyle and jugular tubercle, runs anterolaterally. Again, this is the hypoglossal canal, this is the jugular tubercle, and this is the occipital condyle. Content hypoglossal nerve, meningeal branch of ascending pharyngeal artery, and emissary vein. Stylomastoid foramen. This is the stylomastoid foramen. This is the exit of the facial nerve from the skull. Content facial nerve and stylomastoid artery, located in the temporal bone. Termination, as we said, of the facial nerve, exiting of the facial nerve. So anterior to the mastoid air cells, we will have small foramen. This is the stylomastoid foramen. Regarding ossification of the skull base bones, nearly start 16 weeks in utero. Condensation of the ossification, as we can see, around 24 weeks. Role of CT and MRI, as we all know, CT scan provides information about bony anatomy, pattern of bone destruction, periosseal reaction, sclerosis, ossification, and calcification. Aggressive infections and malignant lesions show permeative and erosive pattern of bone involvement, while smooth cortical expansion and remodeling with cortical thinning is associated with benign, slow-growing processes. MRI has an edge over CT in tissue characterization in general. Inflammatory lesions have higher water content and have high T2 weighted signal intensity. Benign and low-grade tumors also of minor glands, schwannoma, hemangioma, and meningioma have high T2 signal intensity. Malignant neoplasms are cellular and have intermediate signal intensity on T2 weighted images. MRI is superior in detection extension, perineural spread, intracranial, intraorbital extension, and neural compression. Special attention to special areas like the pterygoid region. Now, this is the pterygopalatine fossa, as we can appreciate here. It has a medial end and lateral end. The medial end called the sphenopalatine foramina, here, or the sphenopalatine foramen. And the lateral end called the pterygomaxillary fissure. So the central part is the pterygopalatine fossa, the medial end sphenopalatine foramen, lateral end is pterygomaxillary fissure. Importance of the pterygopalatine fossa, it opens in many regions and many spaces. As we said before, this is the pterygopalatine fossa, and this is the Vidian canal connected to the foramen lacerum. Here, connected to the foramen rotundum and middle cranial fossa. Pterygopalatine fossa communications. It is an important pathway for spread of neoplastic and infectious process. Medially communicates with the nasal cavity via the sphenopalatine foramen. As we said, the inner or medial part is the sphenopalatine foramen connecting to the nasal cavities. Laterally communicate with the masticator space or the infratemporal fossa via the trigomaxillary fissure. We said that the lateral end is the trigomaxillary fissure communicating with the masticator space and middle cranial fossa. Anteriorly communicate with the orbit via the inferior orbital fissure. Here, the inferior orbital fissure. Posteriorly and superiorly communicate with Meckel's cave and cavernous sinus via the foramen rotundum, as we said before. Posteriorly and inferiorly communicate with middle cranial fossa via the Vidian canal, which transmit the Vidian nerves. Inferiorly communicate with the palate via the greater and lesser palatine canal. These are the palatine canal. Lesser is hardly seen. This is the greater palatine canal. As we can see, this is connecting to the palate. Skull base has many fissures and sutures. As we encountered before, trigomaxillary fissure, superior and inferior orbital fissure, and petro-occipital fissure. Also has many sutures like the spheno-squamous, occipitomastoid, spheno-zygomatic, and spheno-occipital. Here spheno-squamous, spheno-squamous, this is occipitomastoid, as we can appreciate. Sella turcica, of course, as we all know, the bony landmark here is the dorsum celli. Here the sella turcica, this is the clivus. In the paramidline, we will have the anteroclinoid process. In the midline, we will have the tuberculum celli, as we can see here. Okay, of course, this is an MRI, contain the pituitary gland. Cavernous sinus and Meckel's cave. This is the region of the cavernous sinus. Here. The Meckel's cave, it is located posterior to the cavernous sinus. Posterior aspect, containing the Gasserian ganglia, sensory root ganglia of trigeminal nerve. The content of the cavernous sinus, containing cranial nerves 3, 4, 6, and the first 2 branches of 5. Also receive superior ophthalmic vein, inferior ophthalmic vein, sphenoparietal vein, sinus, drains via petrosal sinus, basilar plexus, and pterygoid plexus. Remember that the cranial nerves located at the lateral wall, except the 6th or obtusens nerve located inside the cavernous sinus. And as we said, the Meckel's cave located posterior to the cavernous sinus at the region of the petrous apex. So, as we knew, the cranial fossa, it is divided into anterior with its content, middle with its foramina, and posterior with its also foramina. اللهم لك الحمد كما ينبغي لجلال وجهك وعظيم سلطانك. Thank you very much.